So I have shortness of breath with pulmonary edema, including congestive heart failure, which is policy 530.15. One of the things that you need to make sure when you are doing an assessment for this is obviously your ABCs. See if their airway is patent. Make sure there's nothing, no secretions, anything like that. Make sure it's open. Another thing would be the breathing. Obviously, they're short of breath. They're going to be needing some kind of oxygen, so you're going to want to go and get oxygen, whether it be nasal cannula or like high flow non-rebreather. One of the things you need to worry about is fluid in the lungs. Or they'll call us out and they'll have these complaints of water in their lungs, and you can like hear little crackles inside their lungs. And a lot of these patients will say that, hey, I have congestive heart failure, which is usually like a pump failure, which causes like backup issues within the lung, causes excess secretions in the lungs. So like they feel like they're almost like drowning in their own, like they can't breathe right because there's too much water in their lungs. When it comes to patients with pulmonary edema, a lot of them, you'll show up on scene and you'll see various signs that will lead you to like believe, okay, this might be a pulmonary edema kind of call, especially if it's like at nighttime. A lot of these patients will have trouble sleeping because they'll sleep down and then the water will disperse in their lungs, so they'll go throughout their whole surface, so they need to be sit up. A lot of these patients will actually just naturally be sleeping on like a recliner or something like that. You'll see that they'll have swelling in various parts of their bodies, like pedal edema, so they'll have swelling in their like legs. There they can have ascites, which would be like an enlargement of like the stomach. With that, because of the backup with the heart, causes the blood basically not to flow as well as it should, and has the swelling effect. Once you see these patients, one of the key things is to make sure you sit them up, because you want to disperse the fluid that's in their lungs. You want to spread it out, make sure it's in the lower lobes of their lungs. You want to make sure you put a monitor on them, because a lot of these patients will have a certain kind of dysrhythmia, and it kind of gives you an idea of like, oh, maybe an MI related issue. Then you can go ahead and call in for a 12 lead, unless it's an acute onset symptom of pulmonary edema. And based like standing orders, you can go ahead and give or apply the 12 lead, and hopefully that will give you more of a definitive answer. But one of the main things that helps these patients that have pulmonary edema is nitroglycerin. So it'll decrease the preload and the cardiac oxygen demand. You can give up to 3 tablets 3 different times, like 5 minutes apart. So you can give almost 9 tablets of nitro. So you want to make sure you get those vitals early as well, because that'll be helping you out decide where they're at, because it's based off blood pressure. You want to be rechecking every 5 minutes, because if their blood pressure is over 200, then you can go ahead and give them 3 tablets right away. The sublingual, if it's between the range systolic between 120 and 200, then you can go ahead and give 2 tablets, which would be 0.8 milligrams. And then if it ranges from 100 to 120, then you can go ahead and give 0.4 milligrams. But obviously the key for all this is to minimize on-scene time, is just transport. Either stat or not stat, depending on if patient is stable, and go to the nearest hospital with the correct capabilities. While you're en route to the hospital, one of the things you want to keep an eye on for is their breathing. Obviously, you have their oxygen on, but if they can't breathe themselves, and the respiratory rate is like greater than 30, then you're going to want to consider putting CPAP on. The CPAP will definitely decrease the venous return going into the heart, which will also lower blood pressure. Another option in transport would be nitro paste. 1 inch if their systolic is between 100 to 120, or you can go 2 inches on the skin if it's greater than 120. One of the last things that you could really consider would be to start an IV. I would strongly suggest that you don't give any fluids though, because that's the problem they're having now. Too much fluid in their body right now. Some special considerations and priorities would be, if you're doing the 12 lead, make sure you interpret it correctly, and if it shows a current injury, like in possible cardiogenic shock, make sure the destination you choose is the closest facility that can provide a cath lab hospital, which would be either RMC or St. Agnes. Another special consideration to consider would be if you're doing CPAP and it comes to that point where it is severe enough, obviously you're keeping an eye on that blood pressure, but if it falls below like 80, then you just got to stop that CPAP right away and put them back on the non-rebreather, and like continue to monitor that patient. But if it's between 80 and 100, then you want to go ahead and drop the CPAP from 10 to 5 centimeters. And lastly, once you're transported, make sure you call into the hospital what you have with your patient. Briefly but thoroughly explain what is happening to the patient so that they know and understand what's coming, and then they can properly treat this patient. One of the other policies that I have is Bradydysrhythmias ventricular rate less than 60, which is policy number 530.10. With these patients, they have bradycardia, which kind of basically just means they have a slow heart rate. This depends on a few things like the age of the patient or the physical condition of the patient. Like old people are more prone to have bradycardia just because of the wear and tear in their body, and then athletes will normally have it because they've trained their body. Some causes of Bradydysrhythmias that are less than 60 could be that there could be a heart problem. Essentially, the SA node, which is the heart's like natural pacemaker, could just not be firing very well. It could be like a metabolic problem. They could have some sort of heart disease, like EKG rhythms, so you want to have them on the monitor. It could be like a complete heart block or various kind of heart blocks like that would cause various Bradydysrhythmias as well. Also, certain medications have side effects that could cause a Bradydysrhythmia if they either take too many of them by accident. Sometimes it happens with older people, they don't realize what they're taking, or it could be some sort of ingestion as well. Some signs and symptoms be obviously fatigued and weak. Their skin signs will kind of show a little more pale and diaphoretic. Their heart isn't really working very well, so that means oxygen and things isn't traveling very far out to the skin, so their skin colors will change as well. Probably have an altered mental status, feel like they're going to faint, maybe have some episodes of syncope. Some serious signs and symptoms is that a patient may demonstrate like severe chest pain, severe shortness of breath, pulmonary edema could be another one as well. You obviously want to assess these patients. ABCs is obviously the most important part. Make sure their airway is patent, make sure they're breathing okay. You want to assess their chest rise, and then obviously the skin signs. You want to secure the airway if need be, put like an adjunct in there. Obviously oxygen is key, low flow for stable, nasal cannula, and then obviously high flow if it is unstable. IV access is a big thing as well, because you may have to administer medications pretty quickly on these patients. If their blood pressure is less than 90, then that's a kind of another serious warning sign there that you want to be ready for. One of the medications you want to consider giving pretty quickly would be atropine at 0.5 milligrams, either IV or IO. You can consider fluid challenge. I would also worry about if they have the edema, giving a fluid challenge, but that's especially because the blood pressure is at 90. You want to get that fluid going so that you can start to kind of raise that blood pressure and help them out. Blood pressure 90, they have all these signs, then they're definitely going to be a stat patient, so you want to go ahead and transport. Probably give that atropine first, see how that responds. If need be, go ahead and give another 0.5 milligrams of it through the IV, so 1 milligram total. If there's no response to the atropine, then you want to go ahead and do transcutaneous pacing. And so you put the pads on, you want to go ahead and start pretty low with your charge, set it probably around 70 to 80, and you keep an eye on the pacing, and once you finally have capture, then you're going to go ahead and just set it up a little bit more, a little bit higher, probably one more, like 10. You give them a shock every single beat, and you're helping them, and that will definitely bring more oxygen, more blood flowing through the body, and help these patients out. If you're going to be doing this, you also want to consider fentanyl or midazolam. Fentanyl, you can go ahead and give 25 to 100 mics for the IV push for the pain control. So you want to make sure the blood pressure is greater than 90 systolic, and that would only be administered after you have started doing the pacing. Midazolam's good because you can sedate the patient. You can go 1 to 4 milligrams, kind of a slow IV push, or 2 milligrams IM, and that one you can repeat every 5 minutes. Lastly, with most patients, especially if they're stat, you need to contact the hospital. Let them know that they're coming. Unless they're stable. If they're stable and their blood pressure is greater than 90, just go ahead and put on the monitor, make sure you check the rhythm, make sure it's good, and then just transport. If you have an extended transport time, you can go ahead and contact your base hospital For more atropine, another one would be to call in for calcium chloride, 1,000 milligrams or 10 milliliters of 10% IV push. And then lastly, you consider an epinephrine drip, and these are for extended travel times, which would be 1 milligram of 1 to 10,000 in 250 milliliters of normal saline. Some special considerations would be to discontinue the atropine bolus if the grade is greater than 60, because then you've kind of assisted them already. Go ahead and contact the base hospital if their pulse rate is between like 50 and 60 per minute, because then that means they are improving. You want to consider the causes for this. Is it like medications, like I said? Do they have beta blockers? Do they have calcium channel blockers? Is it like a poisoning? Is it overdose of some kind? So just keep an eye on that, medications. When you do administer the medication, you want to allow kind of like 60 seconds of time for the medication to take effect. If you've given that atropine and it actually does raise their heart rate up to kind of around a 50 or 60 beats per minute, you want to go ahead and consider contacting the hospital early, just so they have a greater heads up of what's coming. Another consideration is that when it comes to transcutaneous pacing, you want to make sure you have given that 2 rounds of atropine, so 1 milligram total. And if that has failed to return the patient back to a better rhythm and they're still like hemodynamically unstable, then you want to go to pacing after that. If there's a difficulty in establishing the IV for the atropine administration, you can go ahead and start pacing simultaneously as trying to start the IV, and then go ahead and administer the atropine once the IV is established.